Hello and welcome. Today we're diving into a complex and often overlooked heart condition called cardiac amyloidosis. We'll explore what it is, why it happens, how it affects the heart, and what can be done about it. So, what causes this disease? Cardiac amyloidosis occurs when abnormal proteins, called amyloid fibrils, deposit in the heart tissue. These fibrils interfere with the heart's normal function. There are several types of amyloid proteins that can cause this. One common type is transthyretin, or TTR, where the TTR protein misfolds and forms amyloid. This can be caused by genetic mutations, hereditary TTR amyloidosis, or by related instability of the normal TTR protein wild-type TTR amyloidosis. Another type involves amyloid light chains, or amyloidosis, caused by a plasma cell disorder. In rare cases, other proteins can also lead to amyloid buildup in the heart. Now, let's discuss the pathophysiology. These amyloid fibrils accumulate within the heart muscle, specifically the walls of the ventricles and atria. This infiltration makes the heart muscle stiff and less able to relax properly during diastole, the filling phase of the heartbeat. As a result, the heart can't fill with enough blood, leading to a reduced stroke volume and cardiac output. The stiffening also increases the pressure within the heart chambers. Over time, amyloid deposits can also affect the heart's electrical system, leading to arrhythmias and conduction abnormalities. Furthermore, the heart walls become thicker, which mimics hypertrophy, but without the increase in contractile strength of the normal heart. Cardiac amyloidosis is often underdiagnosed, making precise epidemiology difficult. Amyloidosis is estimated to occur in about 8 to 12 people per million each year. The prevalence of wild-type TTR amyloidosis increases with age, and it's more common in older men. Hereditary TTR amyloidosis varies based on the specific genetic mutation, with certain mutations being more prevalent in specific geographic regions and ethnic groups. Accurate diagnosis and awareness are crucial to better understand the true prevalence of this disease. The signs and symptoms of cardiac amyloidosis can be quite varied and often mimic other heart conditions, which can lead to diagnostic delays. Common symptoms include shortness of breath, especially with exertion fatigue, swelling in the legs and ankles, also known as edema, palpitations or irregular heartbeats, lightheadedness or fainting, and chest pain. Because amyloidosis affects the whole body, patients may have numbness, tingling, or pain in the hands and feet, carpal tunnel syndrome, and an enlarged tongue. These symptoms often develop gradually and worsen over time. Diagnosing cardiac amyloidosis typically involves a combination of tests. An electrocardiogram, or ECG, may show low voltage and other abnormalities. An echocardiogram can reveal a thickened heart muscle and impaired diastolic function. Cardiac MRI is increasingly used to detect amyloid deposits in the heart. A bone scan using a specific radioactive tracer can differentiate between wild-type and hereditary TTR amyloidosis, reducing the need for invasive biopsies. Definitive diagnosis usually requires a biopsy, either from the heart or another affected organ, such as the bone marrow or fat pad. The biopsy sample is then stained to identify amyloid deposits. As we briefly mentioned before, cardiac amyloidosis is classified based on the type of amyloid protein involved. The most common types are AL amyloidosis, TTR amyloidosis, which includes both wild-type and hereditary forms, and in very rare instances, other forms. AL amyloidosis is associated with a plasma cell disorder, while TTR amyloidosis is linked to the TTR protein. Correct classification is crucial because treatment strategies differ depending on the type of amyloid. Treatment for cardiac amyloidosis aims to reduce the production of amyloid proteins, stabilize existing amyloid deposits, and manage the symptoms of heart failure and arrhythmias. For AL amyloidosis, chemotherapy or stem cell transplantation may be used to target the plasma cells producing the amyloid light chains. For TTR amyloidosis, medications like tafamidis, patisiran, and enotersen are available to stabilize the TTR protein or silence the gene that produces it. Diuretics can help manage fluid retention, but they must be used cautiously. Pacemakers or implantable cardioverter, defibrillators, or ICDs may be necessary to treat arrhythmias. Heart transplantation may be an option for select patients with advanced disease, but it's not suitable for everyone. Currently, there are no specific measures to prevent cardiac amyloidosis. For hereditary TTR amyloidosis, genetic counseling and testing can help families identify individuals at risk. Early diagnosis and treatment are critical to slow disease progression and improve outcomes. Maintaining a healthy lifestyle, including regular exercise and a balanced diet, can support overall cardiovascular health, but it will not prevent the deposition of amyloid protein. The prognosis for cardiac amyloidosis varies depending on the type of amyloid, the extent of heart involvement, and the response to treatment. AL amyloidosis tends to have a poorer prognosis than TTR amyloidosis, especially if treatment is delayed. However, newer therapies have significantly improved outcomes for both types of the disease. Recent research focuses on developing more effective treatments, including new drugs that can dissolve or prevent the formation of amyloid deposits. Clinical trials are ongoing to evaluate the safety and efficacy of these novel therapies. Continued research offers hope for improved survival and quality of life for individuals living with cardiac amyloidosis. Thank you for joining us to learn more about this important and complex condition.